All right. So, hello. I'm Sandy Blunt. I'm going to be doing the short version of today's workshop, about a half an hour of talk about, and today focusing on why do integrated behavioral health, why bother, with a particular eye on the situation of the doctor. And I use the word doctor to mean any of the providers. So nurse practitioner, PA, the patients call the person who takes care of them their doctor. And so I find that to be the most useful term, even though other people in the practice may have doctorates. I don't think they'll be offended. So let me share my screen. Oh, come on. There we go. All right. I hope that's the full screen, yes? Okay, can somebody just say that it's working?
It's working.
All right, perfect. Okay, here we go. So we're assuming that you are needing to make the case for behavioral health integration to a practice. I know that many of the practices are very interested and that you don't have to make the case. But when you do, I'm hoping that you will feel that you can represent what the doctor and the practice faces in the way of behavioral health. One of the things that you can say is that integrating behavioral health in primary care is a commitment throughout the country. This is just the federal government's commitment, but whole states are committed to integrated care, whole health systems, major payers, all the uniformed services, Veterans Administration, Indian Health Services, all committed to integrated care. Substantial grant programs funding bringing primary care into mental health centers. HRSA gave $50 million in contracts just to add behavioral health clinicians in federally qualified health centers. And then there's the Agency for Healthcare Research and Quality that has an integration academy and a website. And I give you that website because there's some very good tools on that website. There's a lexicon that carefully defines integration. It's built out of a process from, I guess, 200 of probably the many of the most expert folks in the country have been doing it the most. An atlas of measures of integration, a study called the Guidebook of 9 exemplary practices and what happens there, how it goes into very specific detail as well as looking at general patterns. And then now the playbook. You could use the playbook. You could look over a practice's shoulder as they use the playbook because it will take them from wherever they are and help them outline next steps. And it is a fairly non-prescriptive approach. So it supports the practice in taking its own approach while still giving folks the steps they need to go further. You can start with the idea that if you're talking about the patient-centered medical home and primary care, integrating behavioral health and mental health is now core mission. It's not thought of any longer as just a specialty referral. So here's primary care, addresses the whole person with appropriate clinical and supportive services that include acute, chronic, and preventive care, behavioral and mental health, and they should add, and substance use disorders, oral health, health promotion, and more. Each primary care practice will decide how to provide these services in their clinics or in collaboration with other clinics, with other clinicians outside the clinic. Collaboration is very different from referral out. Let's talk about what behavioral health kinds of needs there are in primary care. Of course, there are mental health needs of all sorts, substance use disorders, and now many are using or trying to deliver medication-assisted treatment or medication-assisted recovery for opioid addiction. There's health behavior change. In order to manage your chronic illness, you're going to need to take the medicine to probably lose weight, maybe change your diet, maybe get more active, maybe stop smoking. All of those are elements of care for many chronic illnesses and just for health. There are a number of what I call ambiguous illnesses, illnesses with medically undiagnosed symptoms, meaning that people come in with what they consider to be medical problems, but the symptoms are related to depression or anxiety. There's a great deal of trauma histories and trauma problems that are caused by or in which trauma is a major player, many discovered and many not discovered, and then serious mental illness in primary care, sometimes with people who are also in mental health treatment, but many folks are not in mental health treatment, and primary care is the only care they get. Here's some statistics on specific diagnoses. The PHQ 3000 is 3,000 citizens who are matched to the population of the US as a whole. So that's a cross-section of the whole country. The Marillac 500 are 500 sequential patients in a safety net clinic. And what you see is, one, that on any given day, 10% of the people in any primary care are likely to meet criteria for major depression. And that's not sort of depressed. That's meeting criteria for major depression. The number of people who are depressed is a good deal higher. The other ones are there, are straightforward, but the take home of this is that people who in what you might call challenged populations or underserved populations, low income populations, they have 2 to 3 times the level of behavioral health need. Then there are all these complaints this is the top 10 complaints in adult primary care. This is the thing that brought them in today, not that they came for a physical, just that this is somebody said, I got to go to the doctor. So of these top 10, when they studied the care that was given and talked to the physicians, what they found was that their doctors found some kind of organic pathology. That means something on exam or something on a test that wasn't right. 15% of the time. That means 85% of the time there are no findings. And what it starts to tell you is that people's life and people's stresses are big players in why they go to the doctor and what they bring to the doctor. And then there's the science of depression, which is that cross-culturally, what we would call depression is mostly appears in physical symptoms. What you would call, what Western culture's sign of depression, Western culture meaning the US and people from Northern European heritage or culture, those folks are down on themselves and they're hopeless and they're guilty and might be suicidal when they're depressed. But not everybody in those cultures experiences it that way. And certainly in other cultures, it's mostly experienced in physical symptoms. And if you have depression, your chronic illness symptoms are going to be worse. The yellow lines there are people with diabetes who are not depressed. And the blue lines are people with diabetes who are depressed, and the likelihood that they will get each of these symptoms of diabetes. You'll notice numb hands and feet are the only ones where the depression doesn't seem to make much difference. That everything else, the depression makes significantly worse. Let's talk a little bit about how this might actually present in primary care. I have here what you might think of as a sort of a doctor's eye view of a person in the next room, coming out of one exam room and going into the next. So in the next room, there's a 35-year-old woman. She has diabetes. Her A1C, hemoglobin A1C is at 10, and that is very concerning. It shouldn't be above 7. She has a BMI, a body mass index reading of 31, which is in the range of obesity. She has a trauma history and seems to have shown some signs of PTSD, though it hasn't been diagnosed. She has depression. She has a history of alcohol abuse, but is currently sober. She's chronically fatigued and has a lot of sleep problems. Her life situation is she has 2 kids, a boy and a girl, 5 and 3. She's divorced. There's a question of that she experienced domestic violence when she was married, but there's been no documentation of that. She has never actually reported it directly. She's currently employed, but she has a history of unemployment. She would be called someone who has shaky employment, but part of that is because her childcare is unreliable. And when her childcare breaks down, then she's often loses her job because she is not skilled enough to be working in a setting where employers have any tolerance for absenteeism. She has a mother and sisters in town, but is cut off from them. They have a family issue that the doctor doesn't know anything about, but knows that they don't speak. And so there's no support there for her. And in fact, it's more than no support. It's a sort of a low-grade anger and hurt that she feels in relation to her family all the time. Her complaint today, and this is her 3rd visit in 2 months, is that she has headaches and muscle aches, and she wonders if she has a brain tumor. So the doctor goes in, and the doctor and the patient are going to have very different experiences of this visit. The doctor comes in, she's pressed for time. and she's pressed for time. Not that she doesn't have her usual amount of time. She has 15 or 20 minutes. That's okay. She'll even stretch a little bit for a person with extra needs, but she's not really optimistic about getting done what she wants to get done. She really wants to talk about taking the meds. Her patient has been prescribed medication, new medication for her diabetes, and tried it for a week and then stopped taking it. She stopped taking it because it didn't make her feel any better. And so she just quit it. So the doc wants to talk about meds. She wants to talk about diet and exercise. They had an agreement last time the patient was in that maybe she would start to change her diet a little bit, cut out sugary drinks, and maybe eat more vegetables and fruits. Problem is that the patient didn't really want to do it, but she tried it a little bit, but her family was so against it. The kids gave her so much static about it that she didn't feel like it was worth it. And besides, the fruits and vegetables cost more money than she has to spend. The doctor is very aware of how grim the future is for this patient with her diabetes not managed. And so she feels like she really wants to urgently get her patient to change in relation to her diabetes, but she also feels like, how's she going to stay connected with her patient if she ignores what the patient brings? So she's going to start addressing the complaint that the patient brings, even though she's pretty sure there won't be any findings. She's reasonably confident that this person does not have a tumor. She's seen her plenty of times and knows that it would be very likely that she would have seen signs long before now. In fact, the doctor feels like psychological and social factors are standing in the way of this patient making progress on the chronic illness. The doctor feels like if she could address the psychological factors, or if she could lower the social stress that her patient has, that getting her to lose weight and take her medicine would be a cinch, but she doesn't know how to do that. The patient starts out worried that the doctor will be mad at her for not doing what she was told to do. She didn't take her medicine. She, in fact, has put on a little weight, hasn't been exercising, and she always worries that the doctor will just drop her. And she notices that the doctor is kind of tense and a little bit preoccupied, and she thinks it's because the doctor doesn't like her. In fact, the doctor likes her fine. She just is frustrated that she doesn't know how to help her. The patient thinks that this talk about diabetes, about blindness and lost limbs and heart disease, is kind of exaggerated. I mean, honest to Pete, is that really going to happen to her? No, she doesn't. None of it feels like that's imminent. And she knows that she exaggerates about dangers to her kids to get them to behave. She tells them that if they run over to the neighbor's yard to play with the dog, that dog will come and bite them. And so she knows the dog wouldn't really bite him, but she just doesn't want her kids to go over there. So she tells a little lie. She thinks the doctor might very well be doing the same thing. And she comes in often really because she at least gets some human caring here. She's a stressed life. She has no partner. She's cut off from her family. And at least when she comes here, someone will lay hands on her and do something that sort of counts as caring. And that brings her back. So the doctor wants to address these social and psychological issues, but she thinks that if she brings in a behavioral health clinician, that could be a time drag. She feels pressed for time already. And if she has to talk to another person about each patient, that doesn't seem like it's doable. She doesn't really know actually what a behavioral health clinician can do beyond address depression and anxiety. And she's never seen the behavioral health clinicians adding value in things like health behavior, or substance abuse, or taking your medicine. All of that she would really like to have happen, it doesn't even occur to her that the patient, that the behavioral health person can do that. And she's not really sure of how you define this person, how you introduce them to patients, how you would get them connected. She doesn't really know how to do that. And she doesn't really actually know what behavioral health clinicians do. I mean, they go behind these closed doors, and maybe they get people to talk about the bad stuff that happened to them, and then they feel better, or it's sort of, they have a friend. She's really, it's not that she doesn't believe they're trained, she just doesn't really get how the whole thing works. And so she would really rather refer. The problem is, referral is often not an option. Working with other settings doesn't work well. They don't share information. You never know what's happening, and if the patient ever gets there. It's been pretty clearly shown that in Steve Bartel's study, where they had the same treatment in both the mental health center and in primary care, same clinicians, and the people who were randomly sent to the mental health center would be given a ride, so that there was absolutely no greater difficulty in going to the mental health center than going to primary care. Still 50% greater uptake of treatment in the primary care setting. People don't like to go to specialty mental health. Plus, if you got them to go, that doesn't get you any more capacity there. You're still looking at 3 to 6 weeks wait, and all kinds of rules and new kinds of insurance issues. And plus, there are many groups who just are not likely to go to specialty mental health. Racial and ethnic minorities just don't, as groups, as cultural groups, tend not to be willing to go compared to whites. And so you end up essentially having no access for folks, both cultural groups and folks who can't imagine going, and folks who think of their symptoms, even though the doctor thinks of them as depression, that they think of them as medical. So primary care is the only setting for a population approach, because people just won't go anywhere else. Plus, if you want to do a PCMH to be a primary patient-centered medical home, now the NCQA requirements say you've got to have screening for depression for adults and adolescents using a standardized tool and a clear set of actions for people who are identified as positive, providing some kind of treatment in the practice. And so if their practice is going to be getting PCMH recognition and payments, they got to think about doing this, and not just depression, for extra credit. And what's extra credit this year is likely to be a requirement next time. you need to be using a standard tool for 2 or more of these other issues. And you're not supposed to screen unless you can offer some kind of treatment for people that you discover as positive. And since we just talked about not being able to refer successfully, this is really going to be the future of primary care, is addressing these issues. Now, when you think about what's in it for the doctor, it's worth making the point that one of the first outcomes of adding behavioral health clinician in primary care is doctor satisfaction. And satisfaction not just with the addition, but with their practice. They like their job better when somebody else is part of the team, because the doctor gets to focus on the areas where they feel most competent, and to be able to involve a behavioral health clinician where they feel they need, when they feel they need help. And so that means they can be more confident that their patients are getting behavioral health care. And so they feel like their practice is doing a better job. It's living up to its mission better. And by the way, primary care doctors, many, in my experience, very many, are mission-driven folks. They would have gone into specialties if they were just in it for the money. And so they like interesting days and lots of different things and taking care of people over long periods of time. So the other thing to think about, and this is something the doctors probably haven't thought about and that you will maybe be able to make the case for as things go along, is that adding a behavioral health clinician can be a way to get to the kind of practice doctors believe in. The behavioral health clinician, with proper training, and we're going to talk about training in other modules about what kind of training needs to be there, but it's a new set, it's a new expertise set. Up to now, they've had the medical expertise set and levels of it, you might say. So nurses have one level and MAs have another level, and the physician or doctor has the most full set, I would say, of medical expertise. Now you have this behavioral expertise, and it improves the behavioral skills of the whole team, assuming that they work together and see each other work from time to time and talk about cases together from time to time. With the new expertise in-house, other team members over time learn to take over functions which further free the doctor. So other team members can be doing behaviorally enhanced outreach phone calls and managing screening and helping with health behavior, motivational interviewing, and so forth. So there are some references for some of the things I said. Let me go back to our meeting and see if there are any questions. I think we have a couple of minutes, or I can just drop off here and you can decide, go further with your workshop.
I did pause the recording, so we decided we weren't going to be doing questions.
But I think we can do questions. I think that's right.
Sandy,
I have a question.
Yes?
My name is Margot Sullivan. I'm a practice facilitator. And my question is, have you had any research findings relative to the physical outcomes that are addressed in the primary care practices with the patients who have had that behavioral health support in those primary care practices? Are they doing better on what the primary care docs are addressing?
Yes. In fact, that's one that has gets measured a lot. The hemoglobin A1C is a good example of a measure that they're going to take anyway, and so
Right.
that they have shown that there is when in integrated care settings in the studies, that not only does the depression measures go down, but the hemoglobin A1C measures improve as well.
Okay, thank you.
Yeah, and I'm not claiming that for every practice. I'm talking about the ones that were studied. And so studies, when you have a study, it's controlled and it's pretty specific what's done.
Right.
But when they've just and some of that has been not with immense complicated kinds of interventions, pretty straightforward outreach and connection, not always with therapists, sometimes with sort of enhanced skilled care managers working with people.
Right. So again, increasing joy in practice for the providers.
Yes.
For everybody.
Exactly.
Thank you.
Sandy, this is Jane, and I've got a question about pediatric primary care. Or
You're going to have to be a little louder, please. Go ahead.
I'm trying to get a mic, Sandy. Pediatrics,
Yep.
primary care. So what's the evidence? What insights can you share with our folks who are working with pediatric practices or family practices serving kids?
The pediatrics is right now hot in integrated care settings because it lagged behind in attention, and now it's getting a lot of attention. So we're finding that the same outcomes in terms of provider satisfaction and people feeling like their patients are getting better care, that's easy. Data on kids with chronic illness is beginning to look good. There's starting to be more organized programs for kids with chronic illness. In places where behavioral health clinicians are really in the flow of care, the outcome is more on sort of smooth care. There are places where the person who goes to the waiting room and brings the parent and the child back for the well child check is the behavioral health clinician. And so they go to the exam room and they have the conversation with the parent and the child about developmental issues, do the developmental screening or the behavioral screening, give advice or teaching to the parent. And so by the time the physician comes in, the behavioral health person has done a substantial amount of addressing the concerns of the parents, because something on the order of 75% of people's concerns when they bring their kid to the doctor are behavioral. And so the behavioral health clinician then can essentially pass this on to the doctor in a nice, with a bow on top. It's organized. It's a clear report. She can talk about the work that the mother and I have, the conversation we had, what the mom is going to try, and the doc can either bless that or add something to it, or if there's a medical piece, do that. So that kind of teaming can be really quite effective. There are others where it's much more sort of co-located, just to have the the services in our place because people aren't going to get them otherwise, and they won't go other places. To go to mental health with my kid says my kid is faulty, is defective to a lot of people, and they're just not going to do it. But to work with somebody in primary care, we had a clinic where I practiced, and we met, one morning a week, and we saw families that were referred by the docs in the clinic. It was myself and a developmental behavioral pediatrician, and we did a 4-visit group of protocol, I guess you'd call it, with these folks. And we were able to address a lot of issues for people and help docs with diagnosis. And I guess maybe 10-15% of the people we saw needed to go on to specialty care, but we were able to address a lot of what people were concerned about because we got them earlier, because people would come when they were just starting to get concerned rather than waiting for things to be out of control and the school to be up in arms and all the other things that I know you all know so well.
Sandy, can you, I just have a question about the pediatric. Is Dr. Briggs of Albert Einstein and Montefiore in the Bronx the kind of top research to look at, or is there other prominent research for pediatrics that you think is also being evaluated?
I could not hear the names that you were citing.
Dr. Briggs, the woman that presented from Montefiore out of the Bronx up at UVM, is she kind of leading the charge on pediatrics?
I don't know her work, but that doesn't mean she's not quite well known.
Okay. Because some of the practices in terms of she had a great presentation. I don't know if you saw it, but she had some ratios about staffing for the pediatric practice, and she had a whole workflow.
That's great.
Yes.
And that is a good example of what's happening now, that someone would have that kind of breakdown or breakout and that information at their fingertips, because not long ago that wouldn't have been there. But I know one of the people that I know who's quite well known, at least as an aggregator of this kind of information, is named William Tynan. He's actually called Doug Tynan, Tynan, and he's at Nemours Health System in Delaware. And he's also the American Psychological Association's person on integrated primary care. If you want, I could get you connected with his information.
Great, that sounds really good. Thank you.
All right.
The second question I have is, so Stephanie and I attended the co-occurring disorders training facilitation yesterday, and we heard a lot, and so they're trying to integrate substance use disorder treatment and mental health into looking at the stages of change. So do you have any words of wisdom in terms of, because the facilitator out of Case Western was really spoke to the fact that this there is not an alignment yet consistently with behavior, the overarching behavioral health, with these two areas of specialty to come together and be seen as a generalist. So do you have any words of wisdom as we move forward and work to integrate in primary care, how to approach that situation when obviously have a substance use crisis, and we're looking at people who may not be familiar, or are familiar with addiction, or are familiar with
right. I do, and I fairly strong words of wisdom on this. The fact that substance use and mental health, bringing them together is called integration by the behavioral health world. The mental health world is sad that's still out there to be done. And it's logical, because what tends to happen is you start with one area like mental health and another area gets left out, and people build a new set of infrastructure to deal with the area that's left out. And there has been lots of struggles between those two areas, and it's a terrible shame. In primary care, it's intolerable to have separateness, because the woman that I used as an example, she has depression, she has alcohol, substance use. Her depression is making her diabetes symptoms worse. I mean, even the idea of co-occurring disorders is a little bit skewed, because they're not two different things that are in one person. There is this soup of pain, and it is behavioral and it is physical, and we try and parse it out by calling one piece of it, depression, and another piece of it diabetes. But really, that's for our sake to think about it. That's not how people experience it. And so unless you have someone there who can go in the door that the patient opens, you are not doing the job. And what I mean is, you have someone who's drinks too much and they are depressed and they have diabetes, and you don't know whether the first thing they're willing to do is to exercise a little bit more for their diabetes care, or to exercise a little bit more for their depression care, or to cut back on a few beers at night for their drinking. But if they cut back their drinking, they're helping their diabetes. If they cut back their drinking, they're helping their depression. So it's not about what you're treating, it's about what definition of the care the patient will resonate with. And that's the piece that makes it so important, that you have a generalist there, that you have a generalist behavioral health clinician who is analogous to the generalist physician who is their colleague. All right, is that, shall I let that be the end, or do you want to?
No, I think that was a great answer. I think that there's still a lot of work just sitting in the room. It was a fabulous conference. They did a great job. I think that there's still a lot to figure out there with the two.
Right. Yeah. The fact that I think that co-occurring disorders is not a great concept doesn't mean that people don't do great work and help patients under that concept.
Yeah. No. I think it was interesting too, because Stephanie and I were the only people that had been primary care. So this was many of the modalities they talked about were new to us, but the concepts were very the same. But you could even see, like, thinking about it, they did this 4 framework, but it wasn't on physical health, and it was on physical psychiatric health and addiction.
Mm-hmm.
So it was just very interesting. But
okay. Well, I'm going to get off now because I've used up a great deal of your experiential time, and I don't want to do too much of that. So I'll see you all again in a couple of weeks, and we'll go on with this process.